Good afternoon, good evening, and thank you very much for sharing that this bit of your evening with us. I'm aware that it's beautiful weather outside, and that doesn't happen that often around here, so we're especially privileged that you came to listen. My name's Joanna Schellenberg. I'm a Professor of Epidemiology and International Health here in the Faculty of Infectious and Tropical Diseases, and it is my pleasure to introduce our speaker and discussant tonight. And I have a little bit to say about each of the two of them. So first of all, to introduce Lars Åke. Lars Åke Persson, he's Swedish. I'm not Swedish. My Swedish is not very good. My best imitation of how to say his name is Lars Åke.
Oh, why not?
Thank you. I'm fluent in Swedish, clearly. So Professor Lars Åke Persson is a paediatrician and epidemiologist. He joined us relatively recently as Professor of Public Health Evaluation here at the school, and he's based in the Ethiopian Public Health Institute in Addis. So it's unusual for Lars to be here in London, and we just take this opportunity for him to give a seminar. So previously Lars was Professor of International Child Health at Uppsala University in Sweden, and he was also Director of Public Health Sciences at ICDDRB, that's in Bangladesh. His research interest has been for a long time intervention research on child survival and early life nutrition, and both short and long-term effects of those interventions. Now, Lars is going to speak, and it's really his seminar, but after Lars speaks, we also are very privileged to have Dr. Audrey Prost with us from UCL. And she's the discussant. She'll speak at the end, give some comments for about 10 minutes, or maybe up to 10 minutes. So Audrey is a reader in global health at UCL's Institute of Global Health. She studied anthropology and ancient history in London and in Paris. And her PhD was on medicine and social change among Tibetan refugees. Then she studied epidemiological research methods, things that are a bit closer to my heart, I would say. And that sparked her interest in mixed methods research. So Audrey has conducted 2 large cluster randomised controlled trials of participatory women's groups to improve maternal and newborn health in eastern India in collaboration with the Indian organisation ECCHUT. So Audrey is really an expert in these women's groups trials, and I think she'll be a brilliant discussant for this particular seminar, which provocatively is called Cutting the Neonatal Mortality Rate in Half. How community groups can save newborn lives. So I want to say that in total, we're pretty determined that this session won't last more than an hour. Lars will speak to us for 30 to 40 minutes, and then Audrey will give some comments. She doesn't have slides, a little bit more informal. Then we will have time for a general discussion, so if you have burning questions or non-burning questions, there will be time for them at the end. But then there are drinks and snacks available right outside. You might have seen them when you came in. So please do come and join us afterwards and get the chance, take that opportunity to talk to Lars Åke and Audrey and anyone else who's here. So without further ado, I want to thank and introduce Lars.
Thank you very much. Nice to be here in this way also. I have of course been coming and going for meetings, etc. But as Joanna said, I spend my time in Addis Ababa with a project which also actually is community mobilization, but in another way, and for in order to increase the healthcare utilization for newborns and children. I'm not going to talk about that today because we have just started that project. So what I will talk about is regarding a project in Vietnam, NeoKIP, Neonatal Knowledge into Practice, which we started a number of years ago. And we have completed that, we have reported it, but some reporting is still going on actually, and I will come back to that. The point of departure was quite similar to other projects regarding newborn health. The experience that the country has been quite successful in reducing under 5 mortality, but not at all successful in reducing neonatal mortality. The curves here are from a health and demographic surveillance system in Vietnam, and the top curve, the under 5 mortality, then we have the infant mortality, the neonatal mortality, the green one. And as you see, quite dramatic history regarding child mortality in Vietnam from the 70s and up to the millennium shift. With the war, of course, that ended in the mid-70s, and you see the peak there in the early 70s, even including the neonatal mortality, actually caused by the bombing of health institutions, which I'm not supposed to say, but every Vietnamese knows that it was a target during the intensified bombing up in the north. And when it stopped, then it's going down, and peace is coming. Later on, they are going into a problematic period with a lot of poverty and misery in society. They were trying to continue with the same kind of political organization when peace was coming as before, and also with the old men in charge of various sectors of society. But we have all heard about the Doi Moi reforms, the renovation of society in the mid-80s. And actually the health reform was the number 1 coming during that period of time. And the dramatic reduction in under 5 mortality when they got better coverage of immunization and better services free of charge for mothers and children. But neonatal mortality continuing on the level of 20 per thousand. So at the millennium shift, exactly the same as the early 70s actually. So that was a starting point. We discussed about what could we do in order to demonstrate that it is possible to reduce mortality. And then we were very much inspired by the women's groups interventions in Nepal and elsewhere. And I shouldn't talk too much about that, but I could mention that it inspired a discussion in the group. Could we do something similar? And we all in the team working together with the colleagues in Vietnam, we knew about the women's organization, which is a very powerful organization in Vietnam. And we were thinking of involving them and creating women's groups, etc. And then our Vietnamese colleagues said, no, it would not work. And why? Yeah, if we create women's groups, no one will listen to them. And why so? We are such a hierarchic society, they said, so it would not work. So what do you suggest? And then they actually suggested the design we have been using. But first, where did we do this? Quang Ninh province, which is a province up in the north. I guess some of you have been to Halong Bay. That's the place. But it's also including a lot of inland and mountain area, etc., up in the north in Vietnam. Quite a variation from modern cities to countryside where you hardly can reach the villages. What they have, and I think it's an important prerequisite for this type of intervention, they have a health system that actually is working, with health centers, with village health workers, with midwives, with doctors at the health centers, and they're actually working at the health center, not only being posted officially, but working there. And they have district hospitals, etc. And in principle, they have referral system, even if they have difficulties in having it running in a smooth way. We did a baseline, and I would like to mention a few details just in order to set the scene. In the baseline in the province, where we were using a methodology with interviews with village health workers that actually kept a book on pregnant women and outcome, etc. It was there in the system. And interviews with midwives at the health centers, also going through their hospital records and triangulation of the information so that we could get hold of all births and all neonatal deaths. And it was 16 per thousand according to our estimate, which was 4 times higher than the official figure. But what was striking was the enormous variation from approximately 10 per thousand in those nice cities along Halong Bay and up to 45 per thousand in the districts in the mountain area. So we had a great inequity. And it was also that those districts with high mortality had a lot of ethnic minorities. In Vietnam, they have a dominant ethnic group. You find it everywhere, but they also have small groupings of ethnic minority groups with different languages, different cultures, etc. And where there are certain challenges regarding healthcare utilization and provision of services. We also found that the neonatal mortality very much was related to the distance to the health institutions. So what they suggested was to have an intervention which related more to the present services as well as people responsible in the local communities. And they pointed out that the Women's Union, they since very long time they have been responsible for maternal and child health activities in the community. So they have been running breastfeeding promotion activities and overall they have been the voice regarding women's health and rights. And the vice chairman in the community, he is responsible for welfare. So we wanted somehow to have the vice chairman involved also. And then of course the local health center with the midwives and the doctors there. And out in the community they have different kinds of village health workers also involved in not only reporting and pushing but also provision of some services, especially on the preventive side. So that was a starting point. And then we had members in the group experienced in implementation research, and they said that it's not just enough to have some groups who are coming and discussing. We need somehow to be a little bit more planned and a bit more scientific in this effort. And the parish framework was a model we were discussing. We have the evidence, what is working regarding neonatal health. We know what to do, etc. The government in Vietnam, they know what to do also. They have very good instructions and guidelines, published guidelines, which also have been used in teaching of health staff in the different provinces, etc. We were very much aware about also contextual differences here, but the focus was very much on facilitation, that we would like to evaluate a facilitated intervention, pushing a bit more, not only having groups discussion. I'm coming back to the slide again. So the idea was that facilitators from the Women's Union who are not expert in health, but they are really experts in mobilizing groups. Working together with the groups composed then of people from local health services. The vice chair from the commune also became the chair of the group, women's organization, village health worker, and having monthly meetings and using this kind of methodology, which is quite common, to identify problems local problems, to plan actions, to do these actions also, and to evaluate what they have done next time or some forthcoming meeting, reconsider the strategy, etc., and to work in this way during 3 years and without any remuneration or top up of salary, which was a challenge. And we had it as a cluster randomized trial with intervention areas or clusters then being communes, where you have then the health center, you have the chair, you have the local women's organization, etc., and then control clusters. And the data collection was independent. So they collected information regarding births and deaths in the same way as the baseline, with triangulation, cross-checking, so that we didn't duplicate any deaths or miss any deaths, etc. And then we had some other data collection methods. We had some nested case reference study in order to look at various background facts. We had verbal autopsy interviews with families who had lost a newborn child, and we had also a series of qualitative sub-studies with facilitators, local stakeholder groups, and so in order to get some understanding of the process. And just to jump to the result after 3 years of intervention, it looked like this. You see the neonatal mortality rates year 1, 2, 3, intervention area, control area, and the adjusted odds ratio there. So control area running 18, 16, 21, intervention area 19, 19, 12. And how come that we don't get an effect, say, year 2, or sliding down? Actually, we did, I'm coming back a bit to that. We did an analysis now afterwards where we had a more time series type of analysis, also including then the seasonal variation and peaks in neonatal mortality. Then actually the effect is much more smooth. But that's a detail. I think this type of intervention is not an intervention where you get the effect immediately afterwards, because you have a number of different actions taken, and some of those are not having effect now, but next time women in the area are pregnant, or it's summing up somehow. We're coming back to that, but just as an initial comment to the latency we see here. We did an equity analysis of the effect of the intervention, and we could see that the neonatal mortality was mainly reduced among the poor. And maybe that's also expected. The poor segments in these societies, the ethnic minority groups, those living in remote areas, of course, that kind of problems were addressed in the intervention. So you maybe you mainly see it in the poor segment. But the mortality reduction was, if you look at education, then it was mainly among those with a bit higher education. Maybe not surprising also, in a way, since the more educated women are maybe more prone to immediately accept and use a bit improved services or opportunities or whatever it could be. Listen to what was happening in society. We did different parts of process analysis, etc. A few comments from that. There were 44 intervention areas. 43 of the 44 groups completed 3 full years, and those that the the group that did not actually finished just a few months before the end. So it was quite remarkable how they were working. You see one such group in action there. 95% of possible monthly meetings were actually performed. The problems focused both the women and the newborns. What was dominating was communication action. It was not so much of reflection that we in the health services, we need to do better job, etc., etc. It was more that women need to understand that, and maybe that's a bit typical for the Vietnamese society also, but it was like that. And one could of course ask, how does it work? And we have got that question many times actually from colleagues, especially those with mainly an experience from hospital work. What was really the intervention? And then we say facilitated groups, so you talk down neonatal mortality. And then they look even more confused. 32 unique problems were identified, groups of problems, 39 unique groups of actions. Totally 933 different actions were taken in the intervention area. And I think this proverb is maybe a good summary of what we believe was happening. Many a little makes a mickle, or I think if you are from Scotland, it should be muckle. So that a lot of many different actions which were somehow making it easier to use the services, the antenatal services, more frequently come to the delivery at health institutions, etc. And maybe also indirectly influencing the provision of services, even if we don't have any proof there. The groups with high-rated quality facilitators, we had an independent assessment of the quality of the facilitation, and those who had a good facilitator actually had a even lower neonatal mortality after the intervention, which indirectly could sort of indicate that actually it was the activity of the groups that made the difference. I would just like to illustrate a few of these problem action things, and the first story here is from up in the mountain areas, a commune with very poor roads, and the maternal and newborn health groups, these groups of stakeholders, they felt that women in the area had little confidence in maternal and newborn health services. They were not using it very much, and even the antenatal care attendance was quite low. And then the group decided that they should be engaged in a strategy to communicate with mothers with 3 different steps, and they started with the loudspeakers. So the health people within the groups, they were sitting down and writing the messages, and not only then informing mothers that they were welcome to come, they were also giving explanations when it was open and when different services were available, etc., etc. That was step number 1, and this was repeated, of course. In Vietnam, they have a tradition that propaganda and information messages are coming through the loudspeakers in every village like that. Second, they had group meetings with women, with the midwife, who tried to motivate and get them engaged, and also, of course, becoming a more familiar face for women in the village. And they talked then about the importance of antenatal, birthing, newborn care services, etc. And then the third step was individual counseling. So the midwife went around and knocking doors and talking to women, etc. And these communication activities then contributed in this village to much better utilization of services. So that was one story of one of the actions, and then of course even these groups continued with other actions. A second example, just in order to illustrate how different it could be. The local health center had been closed down just by a decision from above, and without any replacement. So they were without any place to run antenatal services, etc., and this had not been solved. So now when the group came together and the political people together with the healthcare staff, they said, we can't tolerate this, we need to do something. And then they opened up antenatal and delivery services in the school, and the local politician, the group chair, he assisted in making this possible across the different sectors in society that otherwise are quite difficult to manage in the Vietnamese society. And the midwife also continued with contact with women, and she actually tried to make them to prepare for the delivery, and she advocated quite strongly deliver at the district hospital, and she actually managed to have all deliveries at the district hospital after this, which I think was good, since maybe the school was not optimal to provide those services. A third example, in an area, also very remote area, up in the mountains, very bad roads, and there was concern that so few of the women in the area delivered at health institutions. They were delivering at home, and also they had quite a number of neonatal deaths. When they were busy with this work in order to get women to deliver at health institutions, use the services, etc., they heard from the informants in society that there was a woman who was going to delivery, labor had started, and there were problems. And then they used the group in order to mobilize the village health worker, as well as the midwife and the doctor, some other people from society coming assisting with the transport, and finally they got her down to the health center. They felt that this was obstructed labor, and they arranged by the network and contact in the village transport to the district hospital. And the mother actually could have a vaginal delivery, it was found, but she had very severe anemia. They did the transfusions, and back came then a surviving newborn who most likely had died if they had just stayed at home. So an example that it was also problem solving for individuals in these activities, and enabled by the people in the local community from health sector, political sector, women's union, meeting together. Was the effect of this sustained? We actually went back 3 years after. It's not published yet, but yeah, in the intervention areas where they went down to 12 per thousand in neonatal mortality, 3 years later on they had 11 per thousand, so they were on the same level. And what had happened was that the control areas also had gone down. So we did not see any relapse there, that they were going up in the intervention areas, but there was no continued effect, and that is most likely because the groups did not continue. They said so, but there was no order coming from the provincial level saying that you need to continue this work, and in Vietnam you obey what is said from the top, and you don't take local initiatives. We were also, as I mentioned before, looking with time series analysis what was happening, etc. And it was even more obvious that we actually had a bit of a continuous reduction when you took away the seasonal variation. There was a remarkable seasonal variation actually in neonatal mortality, with deaths in the hot and wet summers. So, to summarize, this intervention then with local stakeholder groups facilitated by women from the local women's union reduced neonatal mortality by half after a latent period of 2 years. Then it came down. The province had a medium level of neonatal mortality, 16. And with great inequities. I think that's also sort of a almost prerequisite for an effect of this kind. You need to have something which is possible to modify by community groups and engagement. And the intervention was poor, but we actually got an increased inequity between maternal educational groups. Good facilitation increased the effect, and we believe that it's a mechanism of action of this kind, with many small details being fixed in the local communities that contribute to a bigger effect. And as I just said, the reduced neonatal mortality rate was sustained in the intervention areas, but the control areas were catching up. Yes.
Thanks very much, Lars. Brilliant. I'm going to hand over to Audrey.
Sure. Can we sit down? Is that okay? Yeah. Okay. Thank you very much, Professor Persson, and thank you all so much for coming tonight. My job is to offer a few comments and some questions, and hopefully we'll have some time to open the floor up for your comments and questions too. I think that the NeoKIP study was really path-breaking for two main reasons. The first is that it was really the first to bridge the community with women's union leaders and chairpersons and facility-based providers. So you had physicians and nurses all coming together as part of a single group doing participatory problem solving and taking actions. And it was really the first trial, to my knowledge, to do that. Previously, people had just worked with women in the community or just done quality improvement cycles with hospitals, but the two groups had never really met and worked together before. So that was really pioneering and inspiring, I think, for many of us. There was also the fact that it was the first trial of a participatory approach in a rural setting that actually had not low, but low to middling neonatal mortality rates. So I think 16 to 24 per 1,000 live births, which is lower to the mortality rates that we had seen in other trials. So the one that I worked in Eastern India had a baseline neonatal mortality rate of 58 per 1,000 live births. In Nepal you had NMRs in the 60s. So here we're talking about a different situation, which is actually perhaps more typical of what we see and will see in the next few years in low and middle income settings. So it's very interesting to see these results in that light as well. So I have a few comments, and I think I'll start with a really difficult one and then move on to the more to the easier ones. So the difficult one, I guess, is around the pathway to impact, and everybody who works with participatory groups or women's groups is asked that question all the time, so you've dealt with it too. But the reason I think it's important to ask it here is because you find a very, very large effect on neonatal mortality, a 50% reduction in the third year of the trial. And this size of reduction, I think, has only been witnessed twice. And once in Abe Bang's pioneering home-based newborn care studies, and that took 10 years to achieve. And the second time was in a setting with a much higher neonatal mortality in Uttar Pradesh in India, with the Shifgar trial that had a similar size of effect. But other interventions have had effects of 20 to 30% reductions in neonatal mortality. So how do we explain the scale of that impact? And if we look at the cause of death data reported in the trial, we see quite a lot of variation year on year on both deaths within causes, but also the number of deaths across the board between intervention and control arm. And so we think about your process evaluation, and many a little makes a muckle. Where are our Scottish friends here? Okay, makes a muckle. And I completely believe that, but what are the specific pathways in which you think that this intervention achieves such a large effect? Related to that, I suppose, is a question on quality of care. If you have NMRs of 16 to 24 per 1,000 live births, to bring them down further, presumably you need action within facilities too to improve quality of care. And it was interesting to see that most of the strategies adopted by the group were outward looking. There were communication strategies, doing counselling, group meetings, disseminating messages through loudspeakers, rather than internal quality improvement action. Do you think that this approach could be adapted or tweaked to maybe focus on some of these quality of care issues in addition to the outward community action? I think maybe that's something that we could discuss a bit further. And I think the final comment and question is about where we go next with these group-based interventions. So we're currently riding an unprecedented wave of support for community engagement for women, children's and adolescents' health. We have a new strategy, the new UN Secretary General strategy, global strategy, that really puts community engagement forward and centre. We also have several models to choose from now when we think about community engagement for maternal and newborn health in particular. So you have people who do home visits, and you think that we should just do home visits. You have people who do group interventions for behavior change using social cognitive theory, for example, to develop their group counseling interventions. You have stakeholder groups. You have people like me who've done, and some of our colleagues here who've done work with participatory learning and action. So these are all very different ways of doing group-based interventions. At the moment, we have WHO modules on caring for children in the community that really only talk about home visits. But clearly there's something going on with groups here, and a number of studies have shown this. Butta's studies, Professor Persson study, our work in several countries too. But which model should we use, and how do we know? And is it possible to have a one-size-fits-all? Should we? How do we take these decisions, and how do we help agencies take these decisions? I don't have the answer to that question. Maybe Lars does, or you do. So these are my brief comments, and perhaps we have time for a response and then a discussion with you.
Do you want me to?
Why not? That's
Yeah.
a good place to start.
Yeah,
Just answer all her questions. It's a good place to start.
No, I mean I fully agree to this. How does it work? I think somehow we are so limited also in the way we are thinking. Rothman has frequently talked about this, that we prefer to have one cause and one effect, and we can tolerate to have a few causes and a few effects, but if it is crossing over and having effects on several, then we are starting to feel to feel confused by that, and that one type of intervention should have several different mechanisms, and that this is having an effect on one outcome, neonatal mortality. That's sort of beyond what we usually believe in. and I think that we, with the accumulating evidence from different types of studies, that actually groups then addressing different problems, solving those problems, that we could have positive effects on maternal and newborn outcomes. It's starting to be quite good evidence that in a way it works. But we could of course be much better in trying to map this. On the other hand, it's quite difficult to be there and understanding all these actions, because I believe, and that was one of your comments, I believe that we also influence a bit of the performance in the health institutions, because when there is engagement out in the community, and actually midwives and doctors are also involved in this, and probably it's influencing a bit on the way they are providing the services also. But not all of it, and coming to this point of quality of care within health centers or hospitals mainly, we got some indirect indication that we didn't, for example, influence what the asphyxia problem. And I think that you need also to have some kind of intervention in the hospitals if you should do something about those things that are more quality of services and so within the hospital walls. We have actually been involved in it's a bit of proof of concept type of continuation of the NeoKIP. We have not published from it yet. We just got data out of it, where we had the community groups like in NeoKIP, and this was in Cao Bang province up in the far north of Vietnam, in the border to China. And then in 4 district hospitals they had similar groups, but then with the professionals within the hospital. But they were very keen also that even the hospital administration and those sitting on money locally were involved in this group. And in Vietnam they have been running audit mechanisms since decades, and usually it has been to blame the youngest doctor of he or she is the cause of all the problem we have in the hospital, that sort of issues. And the experience they have now from these groups within the hospital was that they didn't end up in blaming anybody. It was how can we use our local resources in order to do a better job. And they were very much then using the guidelines from the Minister of Health, so they were sort of checking that they were doing everything in accordance with guidelines, and facilitated by then a person from the regional health bureau. And then we were also trying to get some link between the hospital and the community and what was going on. To some extent it was successful, but not so very much. This continuation of the study was not having the dimension so we can see whether it worked in relation to neonatal mortality, but at least feasibility, and they accepted very much. And they most of these groups in the hospitals, they were saying that we want to continue, please can you fix that from the regional health bureau we get an instruction that we need to continue these groups, and I think that was a good feedback. Yeah.
Okay. I'm going to open the floor for questions. Looking around to see if there are any. There's one there. Anybody else? John? 3? Okay, let's start with those 3.
Yeah, I think my question is, I have seen in my work in Pakistan, enthusiasm of the groups, it flags off after a period of time. But in your case, it seems it was very, sustained over a period of time, and even people asked that they want to continue with it. Can you explain
Yeah.
questions? Yeah.
Sure.
If we can remember that one. Like, how do you sustain that
Yeah.
enthusiasm? Yeah.
I've got two questions, as not allowed. But I'm actually a neonatologist, but I'm doing some distance learning with the school here with my neonatal hat on. I wondered, because your comment at the beginning about the place of women in society, maybe this programme made the women feel empowered in some way, so that they felt it was good to go and seek advice, seek healthcare. And maybe that empowerment isn't easy to measure as such, but maybe that's the pathway. And my second question was what were the main causes of death? Were they prematurity, congenital anomalies, hypoxic ischemia, difficulty?
Two questions there. Thank you, Joy.
I'm going to restrict myself to one question so I'm not in trouble. I'll chat to you about all the very interesting things about, the facilities and the context of society and people do what they're told. But none of you mentioned stillbirths. So, one of the interesting things in your meta-analysis, Audrey, is the effect on stillbirths and how variable that is. And in thinking about pathways, and the pathways particularly for 1.3 million intrapartum stillbirths declared with age, and either the reality of those different deaths or the misclassification. So do you have data, Lars, on the stillbirths? And I noticed that you're an expert on multiple publications out of this. So we would love to see a publication on your stillbirth analysis out of this. And it's lovely to have you on board.
So let's start with your question on sustaining the enthusiasm.
Yeah, I think already in the beginning, our colleagues in Vietnam realized that this could be an issue, and therefore they said we need to have members in the group who already in their job description have this work. So the politician being responsible for health and welfare, women's group members who already are working on this, village health worker who already have this, and then midwives and doctors, of course. So and they said that the trick here is to get them to sit together. It's already in their job description that they have to do this work, but let's try to arrange that they meet once per month. So I think maybe that's and also the backup from regional health bureau and all this. At least in the Vietnamese society, where it's quite important that you have it blessed from above, I think the context really matters, and of course it may be totally different in another country, in another setting. Yes, your first question was a comment. Yes, I think so. And your second question, causes of death, the usual ones, nothing special. So we had the mix of preterm deliveries, and we had, of course, the infections. We had, of course, the asphyxia cases, and a bit of others, but yes.
Stillbirths.
The
stillbirths. Joy's
yes,
question.
exactly. Yes, we have the data, and with enormous misclassification, or rather, we don't want to talk about this. I mean, that's the attitude you find in society, and not only out in the society among the families who prefer not to talk about this as a stillbirth. It's disappearing. They would like it to be a miscarriage and earlier. That's one thing. But it's also within the health institutions in Vietnam. They don't want to talk about the stillbirths. Well, numerically we saw a bit of reduction, but we don't believe in the figures. In our opinion, we got too low figures. It's difficult, but I fully agree with you that it's really important to look into how we should get the good figures describing the situation, and also being able to include this outcome in studies of this kind. True. Yeah.
More questions? Yes. And I'll look around if you have a question. Now is the time. But please go ahead.
Thank you very much for your presentation and comments. My question is about the control clusters. Forgive me if I missed it. Could you just describe where they were physically related to intervention clusters, and whether you had any thoughts on why the neonatal mortality rate went down over time in the 3 years following the study, and could they have adopted some of the practices that were effective in the trial in the intervention clusters?
These groups, one group per cluster, and quite often they were either meeting in the health center of the cluster, which is then in Vietnam they call it a commune, which is a municipality. Then it could be a village or a few villages, or it could be a more urban part, but it is organized so that the political structure coincides with the healthcare structure, and a lot of other sectors in society also. Yes, those figures I showed, that they did so many different things. There were more than 900 actions, but quite often it was regarding communication and fixing of this and that, which included women and the newborn, use of services. I had these stories that they were fixing practical things, and because I think that very often out in low-income settings and low and middle-income settings, the issues that we have there, why people are not using the health services, or that the provision of services is not okay. It's in the details. I'm not coming and delivering because I don't know how to arrange with the transport when it's time for delivery. Or I don't go to the antenatal care because last time when I was there, the midwife was so rude and I don't like her. And then it may be needed with some automation and communication, and so in order to show we have something to offer. Many different things, but I think that mainly the effects we got was the improvement of utilization of services, as well as maybe the content in the services was improved. We got some indications of that numerically also. But if we have a major impact of in a local community that before they were not going to antenatal services almost at all, and afterwards they were doing it, we will not see that in overall figures across intervention and controls. And therefore in different process indicators which you measure across everything, you just get small changes. And it's more informative actually with the qualitative stuff, with the stories telling us that, this was fixed, and then we are starting to understand what kind of mechanism there could be in order to get an overall change.
Okay, we are going to close in a minute. I'm going to ask one last question, which is for both of you. So I find both the women's groups work that you've done, Audrey, and this NeoKIP study, it's completely inspiring. It shows what could be done. There are real gains to be made in neonatal survival and maternal survival with these interventions. Okay, so how do you take them to the next step? What is the next step? How do you take them to scale? And I know Audrey's very much been thinking about that, but maybe just to hear a minute's reflection from each of you on what's the implication of this? It's inspirational, but now what do we do? What do we do differently? So maybe Audrey first and then Lars for the final word.
Well, in India, where I work, we've been involved with the National Health Mission in developing a model to scale up this type of intervention, not stakeholders groups, but women's groups, so mostly based in the community with pregnant women and new mothers, to 10 states using the national cadre called the Accredited Social Health Activists. But it's taken 10 years to get there, and it really 10 years of advocacy at various levels. So it's definitely, and that's a country-specific strategy for many different states. So it takes a lot of time, and it takes a lot of adaptation to local health system. That's a very obvious point. But I was listening to Lars. I was thinking about a paper that's maybe now 10 years old from Kate Kerber and colleagues, in which they looked at the different types of strategies that you need to roll out for different levels of neonatal mortality. And some of them were facility-based and some of them were community-based. And I think that maybe we need to kind of stratify our community engagement strategies based on mortality levels as well. So in settings where you have very high mortality levels in the upper 40s or 50s, then our really community-based work with women's groups, I think, can really cut down some of those infections and hypothermia, and so these really by promoting these essential newborn care practices. And when you start going further down, I think that the stakeholder groups are a really potentially powerful model to bridge the community and the facility. So it was a very long-winded response to your question.
But a good one, I think. Yeah, and Lars?
Yeah, maybe we have to write a paper in order to communicate that kind of strategy. You have expressed it in a bit in some of your previous papers, but I mean, in the recommendations from WHO, etc., they have not really said that this is maybe appropriate when you have a neonatal mortality on this level, and when it's coming down, maybe such and such an approach, and if it is really coming down below 15 and towards 10, etc., maybe you have to look more into the hospital situation.
That's
and
obvious.
etc. No, I don't. I think you exhausted the question and and had a very good answer to that. I mean, there are recommendations from WHO now. What works, what doesn't work, etc. I think we said previously that probably it's not that one costume fits all here. That it's needed in the local setting to think about what is possible in this situation to have some kind of community mobilization activity. I'm convinced that when people in the community are involved in the discussion regarding health services, etc., then you get much better effect, and that holds, I think, for not only low and middle income countries, but in principle for all societies. But you need to have the appropriate strategy for the kind of problems you have, I think.
Okay, thank you very much. Please join me in thanking Lars and let's continue discussions right out there. Thank you.